So can we start with the first paper? Bray and co-workers, personalized uroflowmetry predicts outcome from surgery.
Hi everyone, my name's Alison and I'm a research scientist with the Regional Medical Physics Department, Newcastle upon Tyne NHS Hospitals in the UK. So we know that men with urodynamically proven bladder outlet obstruction experience better symptomatic improvement from bladder outlet surgery than men without. But instead of invasive urodynamics, often maximum flow rate, or Qmax, is measured using a flow test to help select men who should have surgery. And typically, a single measurement of flow rate is made in an outpatient setting. If you take a group of men with lower urinary tract symptoms and measure Qmax, you typically get distributions like this, where around 60% of the men are obstructed on urodynamics and have a maximum flow rate of around 9 milliliters per second on average, shown in red. And the remaining 40% of men who aren't obstructed have a maximum flow rate of around 13 milliliters per second, shown in blue. And the overlap between these distributions is the reason why you can't use Qmax alone to diagnose obstruction. So it's been suggested that multiple measurements of flow rate could be made in each individual, either in the clinic or at home, and then either a maximum or average value be used instead. Using summary statistics reported in the literature, you can predict the distributions of a mean Qmax of, say, 40 measurements made in every man, and there is an improvement in the diagnostic accuracy for obstruction over single measurements due to the reduction in overlap between the obstructed and unobstructed populations. However, in general, the clinical value of maximum flow rate is weakened by its dependence on bladder volume. Ideally, you would evaluate every man's maximum flow rate at the same volume. Attempts have been made to address this by correcting Qmax for volume, either bladder volume or voided volume, or categorizing the Qmax volume pair using nomograms constructed from measurements of flow rate in many men, such as the Sirocki nomogram shown here. The problem with this is that the relationship between Qmax and volume is different for every man, and so making an assumption about this relationship may actually decrease the power to diagnose obstruction or predict treatment outcome. We wanted to investigate whether a maximum flow rate that was corrected for voided volume on an individual level could better predict outcome from surgery than a mean Qmax. So we recruited 30 men who were due to undergo bladder outlet surgery in our institution. We provided all of the men with a low-cost home flow meter for 1 week and asked them to record as many voids as possible. The device, which was developed in our department, obtains Qmax, V-void, date, time, and the full flow trace for all voids. Each man completed an IPSS questionnaire before surgery and then again at least 4 months following surgery so that we could define symptomatic outcome from surgery as the percentage reduction in total IPSS score. So this shows example flow data for one patient. So for each man, we could plot Qmax against V-void for each recorded void. We calculated the mean Qmax for each man. We calculated the linear relationship between Qmax and V-void using a least squares fit. And this allowed us to calculate a volume-corrected Qmax at any chosen volume. So for example, for this man, at 100 milliliters, it was here, at 200 milliliters here, and at 300 here. And so we did this for all volumes between 0 and 500 milliliters at 5 milliliter intervals. And this allowed us to calculate the correlation between surgical outcome and both mean Qmax and volume-corrected Qmax. So as expected, measures of Qmax were inversely correlated with outcome, meaning that men with higher pre-surgery flow rates tended to experience poorer surgical outcome. Mean Qmax showed a moderate inverse correlation with outcome, which was not statistically significant. All values for volume-corrected Qmax for volumes of 150 milliliters and above were strongly and significantly correlated with surgical outcome, with the best performance being achieved at 345 milliliters. So our data may suggest that a volume-corrected Qmax better separates men with low flow rates due to obstruction from both normal men and men with low flow rates simply due to low voided volumes. So we take two patients as an example here. Patient A on the left experienced very good outcome from surgery with a reduction in IPSS score of 94%, whereas patient B on the right experienced a poor outcome from surgery with a reduction of just 29%. Their values of mean Qmax are extremely similar to within 1 milliliter per second, but their linear fits are very different, so that their volume-corrected Qmax at 345 milliliters are 9 milliliters per second apart. Given that the Sirocki nomogram is closely approximated by a quadratic equation, we also looked at using quadratic fits between Qmax and V-void to predict outcome. And although these fits were a better fit to the data points themselves, quadratic fits did not perform as well in terms of predicting outcome. And this suggests that the initial rise of Qmax with volume is clinically more important than the relationship at higher volumes. So in summary, although this was a small pilot study, there is some evidence to suggest that an individual's relationship between Qmax and V-void may be better able to predict surgical outcome than a mean or single value of Qmax. It will be interesting to look at the relationship between results from invasive urodynamics and volume-corrected Qmax, and also to perform a larger, more robust and powerful study of treatment outcome. Thank you.
Dr. Rosier?
I have a question that I want to introduce a little bit. When you average multiple flows of one person, you, of course, gain information, but you also lose information. I will tell you why. If a man voids and he has a big prostate, that is a stable nozzle. And that stable nozzle allows a certain amount of milliliters to pass. It allows 2 milliliters, 3 milliliters, 4 milliliters, 5 milliliters, and 10 milliliters, and 15 milliliters. And in the example that you gave, your patient has, at a certain time, been able to pass 15 milliliters per second. So that was his world record at that time. So the prostate gave way 15 milliliters per second. And you dilute that information in averaging all the flows. So I agree with the flow volume dependency, and you're lucky Professor Halen is in the audience. He can confirm what you said. But the maximum that you can achieve is related to the maximum that the prostate allows to pass. So don't lose the information on the maximum that somebody can perform. And if someone is able to perform only 10 or 9 milliliters per second in your office, and he can do 15 in his home, you're lucky. And you can say, okay, the prostate is less obstructing than I thought. But don't dilute your information in this way as you do.
Next question? Or
Bernie,
comment? Short, if you can.
Yeah, Bernie Halen, Sydney. You've mentioned the Liverpool nomograms in the paper, but you haven't presented any testing of the nomograms with your data. Now, what we found when we did the nomograms is that the people's flow run up the centile charts, and yours are really showing much the same thing, that they run up the centile chart. So I'm just a little bit concerned that you, statistically, why the linear bit? Why don't you just run up the user centile, which we've created, to say, look, the man was on the 35th centile, sorry, on the 15th centile before the operation, and he was on the 25th or 35th after the operation. It seems a bit complicated, and I'm just not... Did you have a statistician with as one of the authors here?
We did have members of the team who are experienced in statistics, but I think the problem with the existing nomograms is that they're based on, generally, one measurement in many men, and you can't always assume that the relationship that comes from one measurement in many men is the same as an individual's relationship, and that's the whole point of obtaining many measurements in one man. It means that you can actually correct volume-wise, dependent on all of his data.
We did test the nomograms at the time, both in men and women, with multiple voids, and they tended to run up the centile charts with the flow rate void to volume, so that I'm not sure that I'd agree with your summation there.
There's some work by Sonke that displays the fact that some men even have a negative relationship between volume and flow, and there's lots and lots of different relationships observed in men with lower urinary tract symptoms in particular. So I think there is value in looking at an individual's relationship.
Well, I have a couple of comments for you. Actually, there are three. First of all, this is a sort of flashback, because those of us who've been in this business for 20 years have done this ages ago. You know, in Nijmegen, they developed home flowmetry, flow meters. They developed the meter, but in the end, Rosier can't confirm, they had to abandon this approach because it didn't have any way. On the other side, I agree with you that flow rate remains the best indicator of obstruction. We just published the first nomogram to diagnose obstruction, and Qmax is by far, you know, the #1 predictor for obstruction. But what I want to challenge, and I'd like the audience to express their thoughts about it, is the idea that patients with obstruction do better on TRP compared to those who are not obstructed. You know, in your presentation, you, if you allow me the term, sell this concept like it is true. And I can tell you it is not true. Because if you go through all the guidelines, you will see that the literature has no consensus at all about patients with obstruction doing better on TRP compared to those who are not obstructed. So is the baseline, is the background of your research, which I'm challenging. Can you defend your point?
The literature that I've looked at does imply that men with obstruction do better by about 10% than men without, according to TURP, and that's the guidance given by the NICE group as well.
But this is not what the guidelines say. And believe me, being in one of the panel of the guidelines in the EAU, I can tell you that we have gone through the literature extensively. And that's the way, this is what the guidelines suggest. Anybody who disagree with me, Rosier. Oh, I was expecting a comment from you. But I mean, you're the only one. Nobody else is disagreeing with me.
I'm afraid that the literature is slightly blurred in this sense. And when you do an analysis of monocenter uncompared studies, you will end up with the result as is in the guideline. If I believe European Urology Guideline, then prostate size is irrelevant. It's not true. There are many, many not referred manuscripts that say that prostate size is very relevant. So like that.
Authored this paper. What I would say is just because there's an absence of evidence in the literature doesn't mean that there's a negative result. So what we really do need is a randomized controlled trial looking at the place for urodynamics. And that's currently underway in the UK.
I'm sorry, but I challenge you when saying lack of evidence. there are numerous studies in the literature. You can challenge the quality of it, but we have been doing these trials for ages, and nobody, particularly in the US, has ever been able to prove what we thought in the early days was true, that patients with obstruction were going to do better, you know, and TAP was a treatment for obstruction. But I mean, if you go and say what you said at the AUA, you know, they will shoot at you, as they did with me years ago. So it's, you know, everybody's just looking for your confirmatory study.
I think we're all agreed in the absence of high-level evidence to answer this question.
Okay, thank you very much. Oh no, Rosier.
Yeah, if you allow me, there's no evidence that patients without obstruction do better, worse, or not, that patients with obstruction do better after surgery. However, patients without obstruction, there is evidence that they do not void better. They have had the surgery, and that has had an effect on symptoms, but they do not void better. So, and there's evidence. So, I think that when there's no outlet obstruction, there are other ways of management apart from making a scar in their urethra.
Okay. We will wait for your confirmation study in future years. Thank you.